Good morning, good afternoon, good evening, everyone. I'm pleased to welcome you to this webinar on the operationalization of vitamin A supplementation in the context of COVID-19. My name is Andreas Hassman. I'm from UNICEF headquarters. This webinar is organized by the Global Alliance for Vitamin A. We hope you will enjoy this discussion today, and that the webinar will be helpful in guiding the implementation of your programs at this very critical time, when we need to protect children and maintain good biannual vitamin A supplementation coverage for 2020. Please introduce yourself by writing your name and institution in the chat box at the bottom of the page, just so we know who you are and who's on the call. You can also use the Q&A area at the bottom of the page to ask questions throughout the session. After the webinar, we will share all presentations as well as the recording. The webinar will be about 90 minutes and consist of 5 main parts. First, we will have a brief introduction from GAVA, then a session on the context in which the operational guidance was developed. This will be followed by a presentation on the content of the operational guidance. And finally, we'll have a Q&A session in which panelists will answer your questions. That's before we conclude and wrap up. And here's a photo introduction to today's presenters, as well as to colleagues, Kuda and Siwai, who will be responding to your questions in the Q&A area as we go along. We will start the presentations with an introduction from Alison Gregg. Alison is the Technical Director of Nutrition International and also the chair of the Global Alliance for Vitamin A, GAVA. Over to you, Alison.
Thank you, Andreas. So I thought we would start by giving an idea of what exactly is the Global Alliance for Vitamin A. GAVA is a technical advisory group and informal alliance of partners committed to supporting countries to scale up and improve their vitamin A supplementation programs in setting where vitamin A deficiency remains a public health problem, as a means to accelerate progress towards child survival and reduce the global impact of vitamin A deficiency. GAVA provides a forum for achieving consensus on research, policy, and program approaches, translating evidence into action, sharing lessons learned, and coordinating policy and guidance, all focused on the role of vitamin A supplementation for preschool children within the context of vitamin A deficiency control and child survival. Apologies, the slide isn't changing. GAVA's goals. GAVA concentrates its work around 4 overarching goals: to catalyze consensus for evidence-based vitamin A supplementation policies and programs, identify and address priority knowledge gaps for vitamin A supplementation, provide program support to improve effective implementation and monitoring of VAS programs, and advocate for political will and sustained attention, as well as for the financial and technical support for vitamin A supplementation where it's needed, all in the context of the broader nutrition landscape. So who is GAVA? The Secretariat is hosted and chaired by Nutrition International, and the core partners that make up GAVA, Nutrition International, Helen Keller International, and HKI, have been partners in vitamin A for over 15 years. We're joined by a range of regular contributors and experts such as WHO, the US CDC, and many academic partners and vitamin A experts around the world, making up a diverse membership. While a lot of our work is at the global level, our partnership is not limited to the global scale. It also extends to the regional and, where possible, the country level. So as mentioned, GAVA endeavors to achieve consensus around a range of issues and to translate global guidance to facilitate its use at the country level. It's for this reason, in this time of the COVID-19 pandemic, GAVA has tried to respond quickly to the emerging need of those on the ground, to review available evidence, come to consensus, and disseminate the most up-to-date recommendations, knowledge, good practice when it comes to adapting VAS programming. Guided by the high-level WHO guidance regarding immunization and other child health and nutrition services, the GAVA partners issued a consensus statement to help guide policy and vitamin A supplementation strategy decisions that needed to be made quickly, as well as develop this operational guidance to help us all plan for and support the necessary training of health workers to continue to safely deliver the life-saving vitamin A supplementation to children while minimizing the risks of transmission. So this webinar has been assembled by UNICEF, HKI, and NI to further disseminate the GAVA operational guidance, which I hope all of you have received and read already, and provide you with this opportunity to hear a slightly deeper dive into the rationale and reasons behind some of the recommendations. And most of all, to open the floor to hear from you, to get your reaction to the guidance, hear your questions, perhaps any clarifications, share your experiences so far, and perhaps suggest additional guidance you would like to receive from GAVA and its partners. So on behalf of GAVA and myself personally from NI, a warm welcome to all of our participants, and I look forward to a rich discussion.
Thank you, Alison, for this introduction. Before we go on to the next presentation, I'd like to invite you to use the Q&A area at the bottom of your page to share your questions. The next presentation will be made by Rolf Clem. Rolf is the Vice President for Nutrition at Helen Keller International, and he's also a Senior Associate at Johns Hopkins Bloomberg School of Public Health. Rolf's presentation will allow us to better understand the context in which the operational guidance was developed. So over to you, Rolf.
Thank you, Andreas, and good morning, good afternoon, and good evening from wherever you're joining this GAVA webinar. As mentioned, my name is Rolf, and in the next 10 minutes, I hope to address two key questions. Why is it critical to ensure that vitamin A supplementation or VAS distribution continues to be provided to children under 5 years of old in the context of COVID-19? And what is GAVA's updated statement and how has it been revised? Vitamin A supplementation is an essential child survival intervention, and because of the role that vitamin A plays in strengthening the immune system and in reducing the risk of mortality in children, it is just as important, if not more so now. COVID-19 has its own health threat to life and health, and it's currently drawing the attention of decision makers. But there is growing concern that COVID-19 response has had a negative effect on the nutritional status of women and children and on essential health and nutrition services like vitamin A supplementation, immunization, and others. We have to remember that even before the COVID pandemic, vitamin A deficiency was and continues to be a major public health problem in many low and middle income countries, affecting 190 million children under the age of 5. And as you know, vitamin A deficiency predisposes children to increased risk of a range of problems, including respiratory diseases, diarrhea, measles, vision problems, and it can lead to death. We also have to remember that before COVID-19, vitamin A deficiency was a prevalent problem in many parts of the world, with little change evident between 1990 and 2013, based on the most recent synthesis of evidence. And particularly in sub-Saharan Africa and South Asia, the prevalence remains almost 50%. We know that there are several complementary public health strategies to address the underlying cause of vitamin A deficiency, even in the context of COVID. And many of you know that these include the promotion of early and exclusive breastfeeding through 6 months of age, the promotion of diverse diets, consumption of biofortified foods and foods that are fortified with vitamin A, such as edible oils and cereal flours. We also know that while vitamin A supplementation is a life-saving intervention, and especially important in high mortality and high prevalence countries, it does not by itself address the underlying dietary causes of vitamin A deficiency. So while there are multiple strategies, vitamin A supplementation is the strategy that has been known to be life-saving. And we've known that for almost 3 decades. And based on rigorous evidence, we know that 1 dose of vitamin A every 4 to 6 months from the age of 6 to 59 months can dramatically reduce deaths by 14 to 24% in settings where vitamin A deficiency is prevalent and under 5 mortality is high. But we also know that before COVID-19, vitamin A supplementation coverage has been losing ground where it matters the most. Here we can see that the proportion of countries with coverage of greater than 80% has decreased dramatically from 2010 to 2016. There's significant concern that COVID-19 responses have had a negative impact on the nutritional status of women and children, and that these could worsen over time for several reasons, including the loss of employment and income, especially among poor households that rely on physical labor, and due to lockdowns, business closures, and restrictions on movement and gatherings of people due to COVID mitigation measures, employment loss and income is substantial. There's also the higher cost of nutritious foods due to supply chain and food production disruptions, as well as the loss of income. And we know that poor people spend a much larger share of their income on food, which means their ability to buy nutritious foods is strongly affected. This can likely worsen the proportion of people that meet the minimum dietary practices, especially in vulnerable populations. There have also been disruptions to health and nutrition services. Significant service disruptions occurred during the Ebola epidemic in West Africa and SARS epidemic in Asia, where outpatient care was reduced by over 25%. And a recent modeling exercise published in The Lancet of the potential impact of COVID-19 related economic deterioration, food insecurity, and interruption of nutrition and health programs suggests that the prevalence of wasting malnutrition could increase by 10 to 50%, with an excess of 40,000 to 2 million deaths. The COVID-19 pandemic has prompted groups like WHO, GAVA, and others to issue guidance to help countries decide whether and how to proceed with essential health services like immunization, vitamin A supplementation, the treatment of acute malnutrition, and other vital services. As you know, WHO declared COVID a pandemic on March 7th. This is an unprecedented and complex pandemic, and the response to it, such as physical distancing, restricting movement of people, the overwhelmed health system responding to the pandemic, diversion of resources to respond to the pandemic, prompted WHO to call for the temporary suspension of mass vaccination campaigns. It also called for adapting routine immunization services where appropriate, so they are conducted under safe conditions and without harm to health workers, caregivers, and the community. On April 7th, GAVA issued a similar statement for vitamin A supplementation campaigns and routine vitamin A, saying that the delivery of VAS through routine health and nutrition services should be guided by local factors, that at that time, mass vitamin A campaigns should be temporarily suspended, that VAS should be distributed along with any outbreak vaccination campaign so as not to miss any opportunities, and that countries should start planning now for intensified catch-up VAS distribution so that they could be implemented as soon as possible when conditions allow. GAVA also committed to updating the guidelines as new information became available. Because outbreaks of vaccine-preventable diseases were starting to pop up, WHO quickly reviewed their blanket recommendation to halt all immunization campaigns and issued an updated guidance, giving some conditions under which campaigns could be considered. Given that vitamin A supplementation campaigns have some similarity to immunization campaigns, GAVA updated its VAS guidance to align with WHO revised guidelines and published those on June 22nd. More countries are trying to find the right balance between preventing the spread of COVID-19 and minimizing disruption to essential health and maternal services. There is no one-size-fits-all balance. Also, the COVID situation is fluid in many countries, so rebalancing efforts are needed as information about viral spread or viral containment emerge. Nonetheless, GAVA's updated statement offers some guiding principles to help countries find a reasonable balance given their local context. For VAS delivered through the existing health services or routine VAS, local factors and local context need to drive local decisions on when and how to deliver VAS and other routine health and nutrition services. But where possible, VAS should be delivered as a package with other essential nutrition and health interventions while practicing COVID infection prevention and control measures. For VAS campaigns, it's critical that the risks and benefits get weighed. There are life-threatening risks associated with not giving VAS, but there are also life-threatening risks associated with giving VAS if appropriate COVID-19 infection prevention measures cannot be assured. So VAS programs are temporarily suspended or the reach of VAS programs is compromised due to health system constraints. Countries need to plan now so that VAS can be started up as soon as possible when conditions allow. We know VAS saves lives and when high coverage is achieved, yet many countries have had to postpone these campaigns due to, as I mentioned, many of the COVID-19 responses. Determining the best course of action in this context is challenging. How should we proceed? Weighing the benefits of a safe and effective intervention that reduces mortality and morbidity against the increasing transmission of a new disease that may burden essential health services can be complex. The starting point for such considerations is a risk-benefit analysis that reviews in detail the epidemiological evidence that weighs the short and medium-term public health consequences of implementing or postponing VAS campaigns against a potential increase in COVID transmission. And it's also important to consider the subnational specificities when going through this decision-making process. GAVA is offering this framework for decision-making steps to help countries decide how to proceed. Step one is to assess the potential benefits of mass vitamin A supplementation campaign and the country's capacity to implement it safely and effectively. Are there enough human resources? Are there adequate material resources, such as personal protective equipment? Is there adequate transport? Are there the necessary funds? And is there surveillance capacity for COVID-19 following the VAS campaign? It's important that countries estimate the public health impact of not conducting the vitamin A supplementation campaign and consider the constraint on health services and disruption of routine health services if a campaign is implemented. We also have to think about the strength of the community engagement and how does the community perceive the risk of COVID and understand the risk communication needs if COVID-19 situation is aggravated due to the VAS campaign. This needs to be weighed against the potential risks of increased COVID transmission associated with the VAS campaign. What is the COVID transmission scenario in the country or affected area? What type and level of control measures and interventions are being imposed by the government, and what's been the community adherence to those measures? Could the risk of COVID-19 transmission be reduced by decentralizing vitamin A supplementation delivery to smaller sites, to limit large gatherings, or by supervised self-administration of VAS? What's the capacity to implement rigorous COVID measures during the VAS campaign and to communicate and engage effectively with the community? These are critical questions to answer to sort of weigh the risks and benefits. So based on a risk-benefit analysis in step one, health authorities can then determine the most appropriate course of action. And again, no one size fits all. If the decision is made to proceed with the VAS campaign, countries should implement best practices such as screening and hygiene, physical distancing, conducting VAS delivery out of doors or in well-ventilated areas, limiting the number of persons, wearing medical masks, and other practices recommended by WHO and local authorities. And if a decision is made not to proceed with VAS campaigns, we really need to reinforce routine VAS, and reassess regularly the epidemiologic scenario, and plan actively and proactively for future catch-up VAS strategies where required. So that's the framework. And interesting enough, several countries have proceeded with VAS programming, and including campaigns in some form, including in Mali, Kenya, Burkina Faso, and Nepal, to name a few. Whether VAS is delivered through a campaign or through existing health platforms, operational guidance is needed to help countries implement best practices. So our next session will offer the how-to or operational guidance for VAS delivery in the context of COVID-19. Thank you.
Thank you, Rolf, for a very comprehensive and interesting presentation. If you have any questions for Rolf, please put them in the Q&A area at the bottom of the screen. I see we're already receiving questions, so thank you very much for your contributions. And please don't hesitate to keep submitting questions. They will be very useful for other participants as well. So the next presentation will be made by Annette Imohe, who is a nutrition specialist at UNICEF headquarters here in New York. Annette will describe the overall considerations for planning for a VAS program in the context of the COVID-19 pandemic. So please, Annette, you have the floor.
Thank you very much, Andreas. I'll first start off by reminding us that the aim of the operational guide is to guide vitamin A program implementers to adopt their programs to ensure continuity of vitamin A supplementation, while ensuring that the risk of transmission of the coronavirus between the health workers and community members is reduced. The guidance is based on overarching IPC concepts that are important to the vitamin A supplementation context, such as physical distancing, hand hygiene, screening for COVID-19, and the use of personal protective equipment. These concepts, in combination with best practices for VAS delivery, form the basis of the guide. First, I'll quickly go over the contents of the operational guide. The guide was put together to provide guidance on three main aspects of planning and implementing vitamin A supplementation delivery during COVID-19. The first section on planning for the delivery of VAS describes the necessary actions critical to the planning process, and the second section provides detailed steps on how to administer vitamin A safely during COVID-19, including the key infection prevention and control measures to keep in mind. The final section of the guide describes the key considerations for setting up and carrying out VAS distribution at the household level and at the fixed sites. We also included 3 annexes to help support operationalizing the recommendations in the guide. The first annex is a table that compares the features and requirements for the 2 methods of VAS administration, which we'll discuss later in this presentation. And this was developed to support subnational managers and management teams to decide which method or methods would be appropriate for use in their region. The second and the third annexes are one-page training tools that include pictorial step-by-step instructions on how to safely administer VAS. The IPC concepts emphasized in the guide apply to all activities related to vitamin A supplementation programs. So, irrespective of the distribution strategy in your country, the COVID-19 context requires us to make some adjustments to the planning process for vitamin A supplementation programs to ensure that programs are safely implemented. With regards to the enabling environment for vitamin A supplementation, program managers should ensure that vitamin A supplementation is included as part of the package of essential child health and nutrition interventions that are being delivered in the context of COVID-19, as Rolf had earlier articulated. In circumstances where there have been changes to the VAS distribution strategy, it is essential to ensure that policies and guidelines are in place to account for these changes. For example, if task shifting to a different cadre of health workers is being done in the current context, then it might be necessary to revise national guidelines to allow for this cadre of health workers to distribute vitamin A. Determining the cadre of health workers to distribute vitamin A is essential, as possible changes in distribution strategy to ensure equitable distribution of vitamin A supplements with minimal risk of infection spread, there may be need for task shifting. We recommend that this is done at a subnational level, as from a planning perspective, there might be different supplies of health workers available in different areas. Training needs should be assessed, and where possible, technology should be leveraged on for training to ensure minimal congregation of health workers. Innovations such as the use of digital curriculums for health workers based on interactive SMS platforms should be considered. Where this is not possible, amendments should be made to the number of health workers per training, with the aim of ensuring small numbers of health workers at each point in time. Attention should be paid to the sitting arrangements to ensure they meet the recommended physical distancing recommendations. Other infection control procedures early mentioned should be instituted during training, such as screening of the health workers, wearing masks, and ensuring hand hygiene. Community engagement will enable identification of potential barriers as a result of the pandemic that may impede program implementation. So strategies to address this will be put in place prior to implementation. It will also identify misconceptions which will be addressed as part of the behavior change communication prior to implementation. Communication is important for beneficiaries to know where and when they can receive vitamin A. This is imperative where the current strategy is a deviation from the normal practice. Information on the importance of vitamin A and how it would be safely distributed would also need to be sent out to ensure that the communities feel safe to receive this service in the current context of the COVID-19 pandemic. The source of information should be from trusted and respected community members. Changes may also be considered to the platforms for dissemination to ensure they align with the physical distancing recommendations. In planning, you also need to take into account the budget that would be needed to support your communication strategy, as this is key to a successful distribution of the vitamin A supplements. It is important to ensure that there's adequate time for supplies to be transmitted from national to lower levels. In the contexts where there have been a change in vitamin A strategy, it is recommended to integrate vitamin A supplies with other existing supplies for health commodities. If adequate supplies are available nationally and there is safe and secure storage at lower levels, pre-positioning of supplies should be considered to mitigate the risk for disruption to the supply chain based on delays or restrictions of movement as a result of the COVID-19 pandemic. Additional resources in the context of COVID-19, such as masks and hand hygiene resources, would need to be quantified and costed. The effect of the COVID-19 pandemic on lead times for delivery should be taken into account when planning. With regards to supervision and monitoring, it is important to explore innovative methods for reporting and supportive supervision that minimize the need for travel and in-person contact. For example, supervision may be done over the phone rather than in person. These modifications will have financial implications that must be costed to ensure that they can adequately be supported. It is important that extra efforts are made to ensure distribution of VAS and the reporting do not decline during the pandemic. I'll hand back over to Andreas now. Thank you.
Thank you very much, Annette. Any questions for Annette, please put them in the Q&A area. We'll now hear from Caitlin Gomez, who is a technical officer at Nutrition International headquarters in Ottawa, Canada. We've just discussed the overall planning considerations, and Caitlin will provide details on best practices and how to operationalize them to ensure that VAS is administered safely. Please, Caitlin, over to you.
Thank you, Andreas. Before we go into the detailed steps of VAS delivery, a decision has to be made on the method of VAS administration that's appropriate for the local context. Traditionally, VAS has been implemented by health workers. However, VAS administration requires the administrator to be within arm's length of the child and caregiver for at least a few moments while the drops are being squeezed into the child's mouth. As everyone is well aware by now, one of the most important ways to reduce the risk of transmission of the COVID-19 virus is to maintain physical distancing of 1 to 2 meters. So this close contact becomes an issue because physical distancing cannot be maintained between the health worker and the caregiver and child. WHO and UNICEF guidance recommends that health workers wear medical masks when physical distancing cannot be maintained. So, where medical masks are available for health workers, GAVA recommends that health workers wear a medical mask while administering VAS. Understanding that medical masks might not be consistently available to all health workers, in scenarios where health workers do not have medical masks, we've developed a second method of administration where the caregiver administers the capsule under supervision of the health worker, and the health worker is able to maintain physical distancing throughout the process. So onto the steps for administering VAS in the context of COVID-19. Shown on the screen are examples from a recent VAS distribution in Kenya, where VAS was distributed at the household level. And as you can see, the visit's taking place outside of the home, which is actually in accordance with GAVA guidance. Before beginning administration, another important recommendation in the GAVA guide is to screen caregivers and children. As per usual VAS protocols, there are no sicknesses or illnesses that prevent children from receiving twice yearly VAS, and that includes suspected or confirmed cases of COVID-19. However, GAVA recommends that caregivers and children be screened immediately prior to VAS administration, and this screening isn't conducted to decide whether or not the child receives VAS. It's done to determine the level of infection prevention and control measures and PPE required, so that the additional steps can be taken to ensure that the administration is done in a safe way. The screening might involve looking for common symptoms of COVID-19, as well as a history of travel to a location with established COVID-19 transmission or contact with a confirmed or probable case. And for more guidance on screening, up-to-date case definitions are available from WHO, and the screening should be done in accordance with local policy on COVID-19 surveillance. So, positive screening, according to local policy, in this case just triggers the use of some additional IPC measures to protect the health worker from exposure to the potential presence of the virus. Specifically, GAVA recommends that VAS administration only proceed in this scenario where health workers are provided with medical masks and also using the caregiver administration method, which I'll explain shortly. So I'll now briefly describe the steps involved in the health worker and caregiver models of VAS administration. You'll notice that the caregiver administration model often involves extra steps, since the necessary tools and materials must be safely passed between the health worker and caregiver while maintaining physical distancing. It's also important during the caregiver model that the health worker explains the process clearly to the caregiver and provides instruction throughout. So to begin the process, the caregiver is asked to place the child's health card on a table and step away from the table. The health worker can then approach the table to pick up the card and confirm the child's age and most recent VAS. In the caregiver model, the health worker also disinfects the scissors and tray and places the scissors on the clean tray. In the next step, those involved in the VAS administration, whether it's the health worker or the health worker and the caregiver, perform hand hygiene. So that's either cleaning their hands with soap and water or with alcohol-based hand rub. The health worker then removes a capsule from the bag or bottle and either cuts it open in the health worker model, or for the caregiver model, they place it on a clean tray and ask the caregiver to open the capsule. Once the capsule is cut, the health worker approaches the child, squeezes the oil into the child's mouth, and steps away from the caregiver and child. In the caregiver model, the capsule is administered by the caregiver. The caregiver is asked to place the empty capsule on the tray and to step away from the tray. The empty capsule fragments are then disposed of safely. In the final steps, the health worker records the VAS administration on their tally sheet or recording tools and on the child health card. The health worker places the child health card on the table, and in the caregiver model, they retrieve the scissors. At the end of the administration, the health worker and caregiver clean their hands. So you'll also notice in the steps in the guide that we're very clear where the health worker is standing in relation to the caregiver and child throughout the process, to emphasize the need for physical distancing. We provided images in the guide to show how this would be operationalized, whether VAS is delivered at fixed sites or at the household level. During health worker administration, even when the health workers are wearing medical masks, the images show that the health worker remains 1 to 2 meters away from the caregiver, caregiver and child as much as possible, whether the distribution occurs at the household level on the left or at fixed sites on the right. So during caregiver administration, the distance must be maintained throughout, as I mentioned earlier, which requires a third space to be established, shown in the images as a spot that is not occupied. When the caregiver needs to, they can approach that unoccupied spot while the health worker is at a safe distance, and vice versa for when the health worker must approach that third space. This extra space is used as a way for the caregiver and health worker to transfer items and tools without having to exchange the items directly through close contact. As the images show, their movement creates a bit of a triangle. So although these diagrams might seem a bit complicated, we really wanted to emphasize that the health worker must be intentional throughout the visit, especially where medical masks are not available, to ensure that they maintain a safe distance to keep themselves and the community safe. So in summary, just to highlight the key differences between the health worker and caregiver administration models, the health worker administration requires that the health worker wear medical masks, whereas caregiver administration requires that the health worker maintain physical distancing throughout the visit. During health worker administration, the health worker cuts open the capsule and squeezes the capsule contents into the child's mouth. But for caregiver administration, the health worker uses a tray or container to transfer the capsule and scissors to the caregiver, and the caregiver cuts open the capsule and squeezes the drops into the child's mouth. While there are risks associated with the caregiver model, we really tried to lay it out so that where there is proper training of health workers, the risks are minimized. We want to emphasize that this is still a health worker managed moment. It's just that the actual actions are being carried out by the caregiver. As I mentioned earlier, a more comprehensive table comparing the two methods is found in Annex 1 of the guide. Lastly, we wanted to highlight some of the extra considerations for VAS distribution at fixed sites, which are outlined in the final section of the guide. Fixed site distribution typically involves large crowds of families waiting for services. So we wanted to provide this guidance to help program managers and implementers make sure they're incorporating the appropriate IPC measures into their programs. So when planning for distribution at fixed sites, it's essential to plan ahead for crowd control. To reduce the number of people at the site each day, strategies such as increasing the number of days VAS is available will help reduce the number of people who come each day. For example, instead of a 5-day VAS campaign, you could increase to a 10-day campaign. Or you could organize the catchment area of each fixed site into small groups, and by engaging with the community through respected and trusted channels, let each group know when they're expected at the fixed site. Lastly, another way to help reduce the number of times each family has to visit a fixed site and thus reduce the risk of crowding is to consider integrating VAS with other essential child health and nutrition interventions. When organizing delivery of VAS at fixed sites in the context of COVID-19, the space and patient flow should be organized so that physical distancing can be ensured at all times. Waiting areas should be marked to encourage this, similar to how circles were drawn on the ground during a recent VAS distribution in Nepal, which is shown in the photo. Since these IPC measures may be unfamiliar to caregivers and children attending the fixed site, it might be necessary to assign personnel to crowd control to help explain the process to visitors and guide their movement. Lastly, there must be hand washing stations available at fixed sites so that all staff, caregivers, and children can clean their hands when entering the distribution site. So I'll pass it back to you, Andreas.
Thank you, Caitlin, for an excellent presentation. Any questions for Caitlin or general comments and observations, questions? Please put them in the Q&A area. We'll start. We'll now go to the last session of the webinar, where we will provide answers to your questions. We'll start off by answering some of the questions that were submitted during registration for the webinar. And after that, we'll move on to some questions submitted during today's webinar. And please keep them coming. Kuda and Siwai will continue to respond in the Q&A area. Right. So before the webinar, one of you asked the following question. Why do you advise that children who are suspected or confirmed COVID-19 cases still be given VAS? Is there any reason not to give VAS to a child during COVID-19? Rolf, would you like to answer that question?
Yeah, I mean, the priority here is obviously getting that child health services related to COVID-19, but there really would be no reason not to provide the child with the supplement unless he was gravely ill. But the child should be given vitamin A supplement even if he has COVID-19. As we know, vitamin A does play a role, at least in boosting some aspects of viral immunity. So it could be potentially beneficial in some general way. But for me, the clear thing is to get the child, to make sure that the child gets the proper health care that he or she needs because of the COVID-19 diagnosis. Over.
Thank you, Rolf, for that answer. We have another question before the webinar. So this one was whether countries have been able to maintain pre-COVID-19 levels of coverage for VAS delivered through routine systems, and whether we can provide some examples of that happening. Alison, would you be able to help us with this question?
So I think this question in particular, looking for examples, I think we were hoping that Kuda and Siwai could give some experiences from their regions. Though I can jump in if that's not possible.
Yes, no, I think that's a good idea. Kuda, are you, and Siwai?
Good afternoon, colleagues. My name is Kuda. I'm a nutrition specialist with the UNICEF Regional Office in Nairobi. And I'll respond first for countries in the Eastern and Southern Africa region. What we've noted is that coverage has been disrupted by the disruption in health services. Currently, we don't have specific data as current countries are still collecting this, and the reporting is a little bit delayed because of the disruption in services. But what we know for sure, based on surveys that we've conducted to countries in our region, is that the uptake of child health and nutrition services has been affected by the COVID lockdowns, also by unavailability of PPE for health workers, as well as some sit-ins and striking of health workers because of this. So the routine service delivery for VAS in a lot of the countries in our region and across Africa has been affected by this. In East Africa, failure to deliver child health and nutrition services has therefore resulted in a decline in number of women actually going to the facility or being reached through campaigns. We've got several countries in the region that normally deliver VAS through campaigns, and unfortunately for semester one, most of those countries have not been able to deliver VAS through campaign. We only have one country, Zambia, out of the 21 countries in our region that recently conducted a campaign. Once we compile the data at the end of this semester, hopefully again, we'll know more on the actual coverage, but we can assume again that children have not been reached with their first dose to the level that they would have been the same time last year. Over to you, Zavai, for the South Asia perspective.
Thank you, Kuda. My name is Zivai, working with the UNICEF Regional Office in Kathmandu, Nepal. Let me start off by saying for the past 3 months, primary health care and nutrition services have largely been disrupted across all countries in the region. And what we've observed is a significant dip and decline in service utilization rates, including vitamin A supplementation, and planned campaign events were deferred as governments mounted COVID mitigation and containment strategies. What we are starting to observe now across the region is some incremental improvements in service utilization. However, coverage is still very low. With recent relaxation of lockdown measures and resumption of primary healthcare services, several countries in the region have started to plan for and implement vitamin A supplementation distribution campaigns. Just this week, Nepal implemented its campaign working with this female community health worker network. We look forward to learning from Nepal's experience and share those lessons with other countries in the region, but also beyond. We also know that Bangladesh is planning a vitamin A campaign sometime next month. In addition, Afghanistan is also preparing a campaign, and Sri Lanka is planning a nutrition month. So gradually, we are starting to see resumption of services, and the guidance being provided by GAVA is certainly useful in terms of ensuring we protect both the caregivers, the young children, and also the health workers, and ensure their safety is guaranteed. We hope through these efforts, the vitamin A supplementation coverage levels would improve within the region. Over.
Hello, Andreas, are you there?
Oh yes, sorry, I was on mute.
Okay.
Yes, I accidentally skipped a question, so we'll just have to go back to a previous question, which was also about routine delivery. So this question was, is the pandemic reason for countries to accelerate the transition from campaign to routine delivery? And it was that question I was intending for you, Alison. So apologies for the mix-up.
No problem. In this is, you know, in settings where campaigns have been halted, quickly getting organized to deliver VAS through the routine system is often the only alternative. So as Rolf was presenting, you know, and what we've all been discussing, especially with all of the questions coming in as well, is this challenge of this very quickly changing environment where, you know, campaigns initially been halted, careful decision, you know, has been taken, okay, to stop the campaign, then you know, ministries of health fully understanding, you know, this is an essential service. Children do need to get vitamin A supplementation. So the alternative is to then quickly look to the routine system. But it is, you know, doing this in a kind of emergency kind of way is very different from an intentional policy shift away from campaigns permanently. So while optimization of the routine child health services is necessary to ensure continuity of VAS during the pandemic, I think what we've seen from, you know, our NI's experience in Africa and other partners supporting governments through that transition, the transition away from campaign needs really benefits from a very systematic approach, and it's simply not possible in a quick emergency situation like what we're faced with currently. So transition generally requires time to develop a well-articulated plan, a roadmap that captures necessary steps to be taken, you know, policy level service provision, extra training, tools and other things that are simply not, you know, always in place in the routine system when a country is used to delivering vitamin A through a campaign, and not the least of which around the readiness of the community to seek services. So generally, if it wasn't, you know, accelerating that transition from campaign to routine is you know, in this setting is sort of generally because it's needed. But a more systematic approach, you know, to make that change permanently is really the way to go. I think that as well as other people have commented, you know, the coverage in, you know, making that quick transition to routine delivery has resulted in some coverage, certainly not the kinds of coverage levels that we'd hope to see, and that we know that children really need to be receiving, especially at this time in increased infection in the community. So I guess I'll leave that there. Thanks.
Thank you, Alison. The next question is about the decision-making framework. So the question that was asked was, the decision-making framework mentions the epidemiological situation, but what about population density? For example, what is the safe modality to implement VAS in a country with a highly dense population like Bangladesh? And conversely, what is the safe modality to reach children under 5 in hard-to-reach areas? Rolf, can you help us with this question?
Yeah, I think population density is an important thing to consider, and it is part of the epidemiological situation. In my view, if the infection, you know, control and prevention measures cannot be well implemented, you know, a densely populated area is certainly a potential risk. And this is even the case in rural areas where, you know, you have people from villages flocking to one area and not maintaining social distance and not having masks. So it is both. So those things I think really need to be considered. I mean, if you're in Dhaka, for example, in a Dhaka slum, it is really difficult to maintain social distancing. Now, that may mean that one could go house to house, which obviously takes a lot more time. But if you can't maintain that social distancing and, you know, the other risk mitigation measures, I would be cautious about. And if there's really little adherence at the population level, I'd be cautious. Hard to reach areas are always hard to reach, and for me, those are usually because of transportation issues. They're difficult. They're isolated areas, and I think again that those populations are probably very vulnerable. You know, as teams go and are transported, even during transportation, one needs to implement the risk mitigation practices. So if that can be done, I think it's still important to reach the hard-to-reach areas because they are probably going to be the ones very they're vulnerable anyway, and they're perhaps even more vulnerable under this the COVID-19 scenario. Over.
Thank you, Rolf, for that answer. So another question was about deworming. Many countries distribute deworming alongside VAS. Does this operational guidance change this strategy? And do you have an answer?
Yes, thank you very much, Andres. I think this question makes a very good point because our operational guidance is focused on only administering vitamin A capsules. However, it does not mean that vitamin A supplementation should be done on its own. In fact, we do recommend that services be co-delivered as much as possible. So while this our guide does not cover logistics on handling of the deworming tablet, many of the same infection prevention and control measures need to be in place which need to be in place for administering vitamin A also come into play for administering deworming tablets. And so it is essential to consider co-distribution as much as possible. Thank you. Over to you, Andreas.
Thank you, Annette, for that answer. So another question was about administration by the caregiver. So a participant asked, the caregiver administration suggestion sounds risky. Why does GAVA recommend this model when we know there are risks? Caitlin, can you answer, please?
Sure, thanks, Andreas. That's a great question. So when weighing the pros and cons between a child getting their VAS versus not getting it, it's better that the child gets their VAS for all the reasons discussed earlier in the presentation. As we know, getting close enough to the child and caregiver to be able to squeeze the contents of the capsule into the child's mouth puts both parties at risk of transmission unless there's adequate PPE for the health worker to wear. But in reality, in some settings, there isn't sufficient PPE available. So instead of not giving VAS because it's too risky to get close, we're recommending the caregiver administration model. Given the risks, it's why we recommend that the health worker be trained on how to carefully instruct the caregiver on how to do it, and for the health worker to closely supervise. It's important that in discussion with governments, we acknowledge that caregiver administration is a last resort method, and it's a mitigation strategy due to shortages of PPE. Thanks, Andreas.
Thank you, Caitlin, for that answer. Yes, so another question was about community health workers. In many countries, community health workers are not permitted to administer VAS. What are the risks and benefits of task shifting to this level of health worker volunteer? Kuda, could you help us with this question, please?
Thank you, Andreas. So this is a very important question. I think because large gatherings are prohibited in the health facilities, it would be better for countries to consider an organized distribution using the door-to-door approach. However, the number of trained health professionals available in most settings in our countries is insufficient for them to distribute VAS to all children in their catchment area. It is therefore recommended to consider having community health workers distribute VAS in the context of COVID-19. And really, again, if they are observing the appropriate IPC measures, this should help in the prevention of transmission of COVID-19. Distribution of vitamin A by community health workers has been done in a number of countries in our region on a regular basis and has not posed any difficulty or challenges. I think the dialogue at national level will need to be around the quick policy shift to where the community health workers can then administer the vitamin A. This is a quick activity that does not require a lot of training from the health worker perspective. So community health workers can be quickly trained and distribute VAS at a community level. And this can help, again, reduce the workload, particularly at the primary health centers and some of the fixed sites. They should also be allowed to distribute VAS, even if it's for a short period. So it could be an interim measure that is being put into place to mitigate, again, the health workload at the facilities. And then this should also be done through official approvals of the Ministries of Health personnel and clear communication to all levels at district, facility, and community levels that this task shifting is now the interim measure that's being taken in the context of COVID-19. But ideally, again, these are the things that need to be considered as and when countries are developing their guidelines on how to deliver essential child health and nutrition services in the context of COVID-19, so that those policy shifts can be put into place, the clear communication made at all levels, and the necessary capacity building conducted at all levels, and that the community health workers can then provide this much needed intervention. Over to you, Andreas.
Thank you very much, Kuda. So the final question we received that we will answer here today was about the implementation and potential challenges. The question was, are there potential implementation challenges, and how can implementation research contribute to address these challenges? So it's clear that COVID-19 is an unprecedented situation, at least in living memory, and it presents several challenges for continued implementation of VAS programs. So implementation challenges might include the mobilization of routine contact points to deliver VAS, the opportunities and challenges involved in caregiver administration, as we just heard, and best practices for carrying out effective remote supervision, remote supported supervision in the context of COVID-19, just to mention a few. And there will also be some challenges around how to integrate VAS with other services in the context of COVID-19 and around co-delivery. So it will be very important to design systematic learning opportunities around these challenges. That's important to inform the response to COVID-19, but also in the longer term, as we look to strengthen VAS programs to be more effective and sustainable or resilient, and so forth. So it's definitely something to look at in more detail in the coming months when we continue with VAS distribution. So those were the pre-prepared questions we received before the webinar. And then we have received a few questions on the in the Q&A function as well that we would like to bring up here. So Naveen asked, COVID-19, is it still believed it transmits from droplets, or is there changing perceptions? Is it going to go airborne? This information is critical to suggest social distancing measures. So, Caitlin, could you answer that question for us?
Sure, Andreas. As we know, the science continues to evolve. Our knowledge on transmission scenarios continues to evolve as the pandemic moves forward. While I can't speak specifically to the latest evidence on transmission, I think it's still emerging, and all of us are, waiting for updates from the WHO. But as GAVA, once confirmed, if there are any changes to the current knowledge on transmission scenarios, the operational guidance for VAS will be updated. Thanks, Andreas.
Great. Thank you for that. Another question was, we're now talking more about volunteers and assume the frontliners are health workers. So support to volunteers is low in the planning process. David, could you talk to this question, please?
Yes, can you come again? Sorry, Andreas, you came a bit low.
Yes, I'm sorry, I'm difficult to hear. We are now talking more about volunteers and assume the frontline workers are health workers. So support to volunteers is low in the planning process. So I guess the question is about how we support volunteers better in this situation.
Okay, sure. Yes, I can give a few insights after. It's very context specific. It really depends on how much you've been using volunteers and for what in the past. Also, the network of volunteers is really important. It varies widely between countries. But in any case, what you will need to ensure is that you have volunteers that are used to minimum extent provide medical services or at least some detection or referral work that are well integrated in the communities. They will definitely need to be trained, which also is going to be a challenge in itself. What we've seen in some countries is small groups of volunteers can be trained at the health facility level, outdoor, respecting like infection control and prevention measures. In any case, they will need to be motivated in a form or another. It can be a financial form. In some countries in Kenya, we don't give them any per diem, but they receive a movement allowance or travel allowance, which is motivating for them. They can also receive some non-financial motivation items like backpacks or t-shirts and things like that. So it's really something that depends on what you've been doing in the past, but for sure, if they are not involved in any form of medical services, preventive services, that's going to be difficult, and it will take a lot of planning from the beginning and a careful consideration. Over.
Great, thank you, David. Another question was about the cost and the cost effectiveness of the VAS in the context of COVID-19. So COVID-19 has increased cost of the intervention. It is now more. It's now more than 2 cents per child reached. In this context, how do we make VAS distribution more cost-effective and cost-efficient? Rolf, could you give an answer?
Yeah, well, I think it's important to realize it's never been 2 cents per child reached. 2 cents is the cost of the capsule. The biggest cost really is in its delivery, which really means people. And it's true that the costs have increased mostly because of the need for the protective, the personal protective equipment, and engaging the community more on changed modalities. Again, not doing VAS has its costs in terms of lives lost. It is going to be more expensive and to do VAS or any of the other services because of COVID. That's just the reality now. One way of reducing costs is to package services so that you minimize the number of contacts and you maximize or optimize each contact that you have, so that you spread the cost over multiple essential interventions directed to the child or to that child's mother. So that would be sort of my thinking right now, in terms of how you might improve the cost effectiveness, really by combining the delivery of multiple critical services that target that child. Over.
Thank you, Rolf. So another question is about documenting the stories and the experience from different countries. So how is GAVA supporting in documenting stories from different countries on VAS dosing? VAS partners have been documenting the experience in countries, particularly focusing on the transition from mainly routine to mainly routine delivery, and that those activities will continue with a focus on how countries are coping in the situation we are in with COVID-19. So maybe adding more facets to those documentations, but really continuing with a focus on actions in countries. So you should hear much more about that in the months to come. Then there is another question from Noreen. In countries where VAS is through campaign style and linked with other health interventions, but due to COVID, the campaign is suspended and the option is to switch from campaign to routine supplementation is more challenging when the HCP at fixed sites are not trained for VAS. The government is also facing issues with essential routine services. So maybe more a comment than a question. Banda, would you like to come in and respond? Hello, Banda.
So it's possible. Are you muted, Banda?
Yes, we're not hearing
okay.
you.
So perhaps it's Alison here, so maybe I'll jump in.
Yes, thank you.
Yeah. So the this is you know, hearing your comment or question, it is very common that we're seeing this all over, and this is you know, the challenge of this kind of rapid default to delivering VAS through routine services, and as we were mentioning before, you know, it's not optimal. It's in most cases it's kind of a last minute resort to it. So rapidly being able to get some training in place, adapting some tools, some quick fixes to ensure that the health workers who are at the routine sites are at minimum trained on administering the capsule, reminded of their probably earlier training on that, etc. You know, really is needed. You know, this is combined with low uptake of routine services, understanding that in the COVID. So there is some, you know, community communication required, some intensified BCI, whether that's through, you know, mobile phones and other things, to notify the community what services countries, you know, what the geographies, I wouldn't even say countries, I know it's different at subnational levels, but in some, what services are being offered through routine, and some sort of social mobilization around that, reminding caregivers to bring their children for their VAS, especially for those that would have received it in a campaign, maybe in the month of April or May or June. Those children have already gone, you know, 6-7 months since their previous dose, if it's a campaign country. So yeah, definitely this is a challenge that all governments are facing, is this quick shift. There are some experiences, you know, as GAVA, we're going to try to put out as much as possible some of these sort of quick guidance on a transition to routine, some lessons learned from those countries that have made that transition in a slow and methodical pace, and try to disseminate that as quickly as possible. So I hope that helps a little bit.
Yes, thank you, Alison. I think Banda is back with us. Anything to add to what Alison just said? I don't know if you heard all of it, but anything you want to add?
No, I don't have much more to add. Just that I think that we can also really think about using mobile technology in case people, health workers at fixed staff are not trained, we can use mobile technology to provide some guidance to those kind of staff. Also is something to consider. Over to you.
Thank you, Banda. I think this will take us to the end of our Q&A session. So, dear participants, dear panelists, and Q&A facilitators, a big thanks to you all for a very rich and productive.
There's one last question that just arrived, Andres.
Okay.
I can try if you want. Yeah. It's about the red and the blue capsules. That's for sure that if you are asking caregivers to give the vitamin A because there is a lack of protective equipment, it's going to be even more difficult if you don't have blue capsules. So if you have to ask the caregiver to only give half the red one, that's going to make it challenging. So we would definitely recommend that you try as much as possible to ensure blue capsules are available for children 6 to 12 months. Otherwise, that's for sure it will give an extra difficulty, but it's still feasible. We can still ask the caregiver to give half the capsule, knowing that the risk, if there is one extra drop given to the child, is the risk for the health of the child is extremely limited. So I think as much as possible, try to have the right capsules. If you can't, it should not make you not give vitamin A to the children less than 12. Over.
That's great. I'm glad we managed to include that. That was an important question. Any other questions we need to address? Or great. In that case, we will move to the final bit of the final section of the webinar. We'll get back to you following the webinar if there are any questions that we did not manage to cover in full during this Q&A session. But now I would like to hand back to Alison for final remarks. Over to you, Alison.
Thanks, Andres. And thanks everyone for all of those questions. I hope we were able to answer them adequately. As you can tell, as with everyone, with so much emerging and changing very quickly, there's not always a perfect answer to all of these kinds of questions. But really, I think what we're trying to do and is try to keep principles consistent. Try to do the best to find the most viable solution, that us concentrating, of course, on making sure that children are getting their age-appropriate dose and they're not going too long between, from their last dose. We don't really know how long this situation is going to continue. And so really working to find sort of this best interim solution, both from what platforms to use to deliver VAS, how to ensure a continued availability of PPE equipment. This is going to become a challenge, of course, for budgeting and things like that. So, but putting these best practices in place as we go really is I think our way forward. So so just in summary, we're reminded today about the importance of VAS for child survival, where vitamin A deficiency remains a public health problem, how the challenge of keeping 2-dose coverage high has become even more challenging in this context, the importance of adequately planning and planning a bit on the fly, planning and then planning again as situation changes. As well as the options we have at the moment for different administration models based on infection rates and availability of PPE. Again, that situation is rather fluid and is going to continue to change. As you've noted as well, there were some questions that came in on the around India, the country that uses vitamin A syrup. So, at the moment, those are rather exceptional situations. Most of this guidance has been around the vitamin A capsule. So I hope we were able to answer your questions around the administration of syrup using a spoon, as well as understanding that that is also a very challenging situation that India is facing. So we hope that you found this useful. As next steps, as mentioned before, we're going to be sharing the recording and the presentation with all the registered participants in the coming days. And just a reminder to, if you haven't already done so, to please sign up for the GAVA newsletter on the GAVA website, and this will ensure that you don't miss any future updates as well. So I think for now, sort of as chair of GAVA and from Nutrition International, on behalf of the GAVA partners, UNICEF, HKI, and NI, we thank you very much for participating. Thanks.